Okay, this patient's fatigue, find facial here. This patient fatigue, find facial here. Lanugo, dental erosion, excessive exercise, likely as an compensatory behavior are suggestive of bulimia nervosa. Bulimia nervosa is characterized by episodes of binge eating followed by purging, most often via self-induced vomiting. Chronic vomiting leads to volume depletion, near syncope, sinus tachycardia, and metabolic alkalosis. Elevated serum bicarbonate. Vomiting leads to loss of hydrogen. Vomiting leads to loss of hydrogen and chloride from the gastrointestinal tract. This results in net gain in bicarbonate that initiates metabolic alkalosis. The kidneys respond by attempting the kidneys respond by attempting to eliminate the alkali load. However, they are unable to do because the low chloride from vomiting impairs renal bicarbonate excretion. Therefore, chloride depletion perpetuates metabolic alkalosis. It is confirmed by low urine chloride. Treatment with normal saline replenish both intravascular volume and chloride, and thereby restoring the kidney's ability to excrete bicarbonate and correcting the alkalosis, saline responsive metabolic alkalosis. Look at the box of the low urine chloride. If there is metabolic alkalosis like pH more than 7.45, bicarbonate more than 24, the next thing we need to do is to urine chloride. If urine chloride is low, that is saline responsive, and the cause are vomiting, nasogastric aspiration, and diuretic overuse. If urine chloride is high, more than 20, high urine chloride, then is it hypovolemic or hypervolemic? If it is hypovolemic, it is Barter and Gittelman, and if it is hypervolemic, it may be due to primary primary hyperaldosteronism, Cushing syndrome, and ectopic ACTH production, unresponsive. These are the saline unresponsive cause. Okay. You don't like to remember the boxes, isn't it? Yes. So hypokalemic, hypochloremic metabolic alkalosis, gastric suction or vomiting, loop or hazard diuretics. Pathophysiology is gastric and renal hydrogen losses initiate gastric and renal hydrogen losses initiate alkalosis, volume depletion, activate RAS, increase renal potassium and hydrogen loss cause hypokalemia and worsen alkalosis, chloride than relative greater loss of chloride than sodium, profound chloride depletion and impairs decreased chloride impairs bicarbonate excretion which perpetuate alkalosis. Management is removal of the initiating factor and chloride replenishment with normal saline which corrects alkalosis. Yes. Wait, wait. Just remember the first box. Like if hematuria more than 3 RBC, is it? Then it is. Then what would be the area where the hematuria is happening? Like if we classify hematuria, what can be its classification? Yes. Okay, then give your answer. If acetaminophen, okay. It's very Okay, this is a complex question, so mm, uh, we need to study all the options. Okay. Okay, hematuria results from glomerular or non-glomerular source. Non-glomerular, more common, can be gross or microscopic and is characterized by bright red or pink color, normal appearing red blood cell, limited proteinuria less than 500. Non-glomerular is limited proteinuria less than 500 milligram per day. There is 2 plus protein in here. Okay. So one clue that it is glomerular, because proteinuria, if it is more than 1 plus, it means more than 500 milligram per day of protein loss. So looks like he has a glomerular one. Okay, you got my point. Look at the box in the above. They said that proteinuria, often 1 plus, means more than 500 milligram per day. So in here, in this stem, protein is 2 plus, so it is glomerular, more than near about 1000 milligram, maybe. Okay. And another thing, glomerular has red or pink color hematuria, red or pink color urine. Okay. Common causes include infection, nephrolithiasis, cancer, renal cell carcinoma, urogenital trauma. Associated symptom, dysuria, unilateral flank pain often provide diagnostic clue. In contrast, glomerular hematuria typically microscopic, uh, although gross is sometimes present. It usually results from immune-mediated glomerular injury, glomerulonephritis, which produces dysmorphic RBC, RBC squeezing through the damaged glomerular basement membrane, and RBC casts. However, the absence of dysmorphic RBC or RBC casts do not exclude glomerular bleeding. Both finding can be missed for various reasons, prolonged centrifugation. Therefore, other signs of potential glomerular injury should be noted. Dark red or brown color hemoglobin oxidizes to methemoglobin during prolonged nephron transport, and albuminuria, glomerular proteinuria, urine dipstick is specific. Higher quantitative levels more than 500 milligram per day are suggestive. This patient's albuminuria 2 plus dipstick, dark red urine, albeit transient. I don't know what does mean. And bilateral flank pain versus unilateral, suggesting non-glomerular cause. So 2 plus protein, dark red urine, and bilateral flank pain are consistent with glomerular hematuria. Concurrent pharyngitis suggests glomerulonephritis, most likely IgA nephropathy. It was a clue. I missed. Prostate and bladder disorder, malignancy, hyperplasia. Prostate and bladder disorder, malignancy, hyperplasia infection causes non-glomerular hematuria. Moreover, this young patient is unlikely to have urogenital malignancy or benign prostatic hyperplasia. There is no evidence of infection. There is no evidence of infection by symptoms, dysuria, or urine analysis negative leukocytosis. No pyuria defined as more than 10 white blood cell per eye per field. Okay, option C and D Acute interstitial nephritis most commonly follows the drug exposure antibiotic and can cause glomerular hematuria. However, urine analysis show white blood cell counts lacking in this patient. So AIN need white blood cell counts lacking in this patient, and acetaminophen is unlikely the cause. Chronic interstitial nephritis in can result from acetaminophen. However, long-term intake is characteristics. Interstitial inflammation from CIN. Interstitial inflammation from CIN can be cause of renal papillary necrosis from papillary artery ischemia. However, this patient lacks CIN pyuria and has no evidence of other RPN predisposing disorder, ischemia prone disorder as sickle cell. Acute tubular necrosis results from hypotensive or nephrotoxic injury. Urine analysis classically show muddy brown cast without significant hematuria or proteinuria. Tumor originate from renal tubular renal cell, cause non-glomerular hematuria without significant proteinuria. Yes, glomerular hematuria. In glomerular hematuria, RBC cast may be seen. Non-glomerular RBC cast is absent. Dysmorphic RBC often present, and non-glomerular rarely or usually normal. Proteinuria 1 plus, often 1 plus, more than 500 milligram per day. Usually negative or trace less than 500 milligram per day. Color is dark red or brown, cola or tea colored, and non-glomerular is bright red or pink color. Clots absent, and non-glomerular clots are possible. Okay. Okay. We need to remember the association. Um, this patient with edema marked proteinuria. This patient with edema marked proteinuria and has nephrotic syndrome from membranous nephropathy, which is due to accumulation of subepithelial immune deposits. Although membranous nephropathy is often idiopathic or primary, autoantibodies against endogenous glomerular antigen in adults, the diagnosis should be prompt and evaluation for secondary causes, particularly in children who rarely develop primary disease. The finding consistent with membranous nephropathy. Malignancy, infection, autoimmune disease and drugs, malignancy, solid tumor in adults, infection, hepatitis B, C, syphilis, autoimmune disease, SLE, thyroiditis, and drugs like NSAIDs. Because membranous nephropathy pathogenesis involves gradual podocyte damage from accumulating immune deposits. Gradual podocyte damage from accumulating immune deposit. Onset is typically subacute, unlike other nephrotic syndrome that presents acutely minimal change disease. In patients with hepatitis B virus, membranous nephropathy is caused by immune complex formed from hepatitis B E antigen and anti-HBe AG. Therefore, chronic hepatitis B infection is a significant risk factor for membranous nephropathy, particularly in children. Evaluating all patients with membranous nephropathy with hepatitis B serology is recommended, although universal hepatitis B vaccination had reduced the rates of HB associated membranous nephropathy. Okay, okay. Sorry. Okay. So it is renal tubular acidosis, probably renal tubular acidosis type 1. In type 1, pH is more than 5.5, and in type 2 and 4, pH is less than 5.5. You can figure it out, the renal tubular acidosis, with urine pH and potassium. If urine pH is more than 5.5, it is 1, and in 2 and 4, urine pH is less than 5.5. Yes, in R in RTA type 1, urine pH is more than 5.5, and in 2 and 4 urine pH is less than 5.5. And if you look at the urine, sorry, serum potassium is low in 1 and 2, and serum potassium is high in 4. 1 2 serum potassium is low, and in type 4 serum potassium is high. Yes. Okay, I'm reading the explanation now. So serum this infant has low serum bicarbonate and a normal and a normal anion gap. Then lab findings are consistent with NAGMA, non-anion gap metabolic acidosis. NAGMA typically results from renal or GI loss of bicarbonate, leading to relative increase in hydrogen ion along with serum along with increase in serum chloride to maintain electronegative balance, as seen here in this child with poor poor growth without diarrhea renal tubular acid poor growth without diarrhea renal tubular acidosis is suspected. RTA can be inherited or acquired. Defect in the ability of the renal tubular to reabsorb bicarbonate in type 2 or excrete hydrogen in type 1. In type 1, there is decreased hydrogen excretion from alpha intercalated cell, and in type 2, there is decreased bicarbonate reabsorption. Okay, infant often have growth failure due to chronic acidosis, and the specific lab abnormalities depend on the RTA subtype. In this patient, the alkalotic urine, in this patient with alkalotic urine, urine pH more than 5.5 is consistent with type 1 RTA, in which distal distal convoluted tubule fails to secrete hydrogen ion because bicarbonate cannot be generated and reabsorbed. Acidosis occurs. Conversely, defective bicarbonate reabsorption from in the proximal convoluted tubule leads to type 2 RTA or Fanconi syndrome, which is characterized by generalized proximal renal tubular dysfunction and loss of other substances like glycosuria, as seen in this patient. Urine pH is typically less than 5.5, and serum bicarbonate is so depleted that has little remains to be secreted in the urine. Hypokalemia is seen in both conditions. Okay, in type 1 and type 2 there is hypokalemia that they are trying to maintain. Next. Okay, it's retrograde cystography. Okay, in this patient has blunt abdominal trauma, bat has suprapubic. This patient has blunt abdominal trauma, has suprapubic tenderness, hematuria, and intraperitoneal fluid on fast. Intraperitoneal fluid with fast. This patient is most concerning for intraperitoneal bladder rupture and should be evaluated with cystography. Blunt abdominal trauma can abruptly increase in intravesical pressure and rupture the bladder as it is the weakest part of the dome. As its weakest part, like dome, peritonitis often peritonitis often does not develop acutely because urine is typically sterile. Instead, the most common clinical findings of bladder rupture are hematuria, suprapubic tenderness, difficulty voiding, associated pelvic rupture, retrograde cystography in which bladder is passively filled by a Foley's catheter with water-soluble contrast, then imaged CT scan can confirm the diagnosis. Surgical repair is required for intraperitoneal rupture because continued efflux of urine through the defect prevents spontaneous healing. So retrograde cystography, when we are doing in blunt abdominal trauma, always rup- bladder rupture, because in yes, in this there is no retrograde cystography. It, like in bat, this flowchart I am talking about, this flowchart. Yes, hemodynamically unstable. If peritonitis, go for laparotomy. If no peritonitis, fluid, free fluid on fast. So there is free fluid on the first scan. If there is free fluid on fast, do laparotomy. If there is no free fluid on fast or inconclusive, consider CTAP, cirrhosis of the abdomen and the pelvis after resuscitation, or DPL, diagnostic peritoneal lavage, for other sources of hemorrhage. If the patient is hemodynamically stable, peritonitis positive, laparotomy. If free fluid on fast, positive, CTAP. If free fluid on fast, positive. If free fluid on the fast is positive, do CT scan of the abdomen and pelvis. If it is inconclusive, consider CTAP, CT scan of the abdomen and pelvis, or serial abdominal ultrasound based on the suspicion for intra-abdominal injury. My question is when we will do retrograde cystography. Okay, so he is hemodynamically stable. Okay. Yes. Is it tubular interstitial nephritis because of white blood cell cause? So this patient elevated serum creatinine indicates this patient's elevated serum creatinine indicates kidney injury, a kidney injury of unknown chronicity in which patients with unknown baseline creatinine renal ultrasound can help distinguish the chronicity of the injury. Bilateral small kidneys on ultrasonography suggest chronic kidney disease. The presence of elevated urine, the presence of elevated urine WBC and WBC cause indicative of tubular interstitial nephritis. Inflammation of the tubule and the interstitium often referred to as interstitial nephritis, often with analgesic use for back pain, and raises suspicion for analgesic nephropathy, a form of chronic nephritis. Analgesic nephropathy is thought to result from long-term use, combination analgesia, most notably acetaminophen, in combination with aspirin and or other non-steroidal anti-inflammatory drug. And its metabolites, acetaminophen and its metabolite cause direct renal toxicity via lipid peroxidation. The direct toxicity potentiated by depletion of the glutathione by aspirin, which reduces the capacity to detoxify the reactive uh, acetaminophen metabolites. In addition to chronic kidney disease, addition to CIN, analgesic nephropathy can also manifest papillary necrosis, commonly uses flank pain, hematuria. CT scan may usually often helpful in diagnosis of analgesic nephropathy, sometimes showing renal papillary calcification and irregular kidney contours. Okay, Okay, can you give me 2 minute break? I'm coming. Okay. Yes, now. Okay, I'm reading the explanation. Nocturnal anaeresis. Mm, Nocturnal anaeresis refers to nighttime urinary incontinence bedwetting in children aged more than 5. Anaeresis is particularly common in young boys. Anaeresis Anaeresis is particularly common in young boys and is typically isolated. In isolated condition, the sun that self-resolves in early childhood. However, an underlying cause should be suspected in a child with a new or worsening symptom, as seen in this patient. Constipation is associated with bladder dysfunction and should be considered in any patient with anaerosis because the close proximity because the close proximity because mm, constipation is commonly associated with bladder dysfunction and should be considered in any patient with anaerosis. Because of the close proximity of the bladder to the rectum, fecal retention can lead to decreased functional bladder capacity and instability of the detrusor muscle of the bladder, because often mistaken as diarrhea. In copracesis like fecal incontinence is usually a sign of constipation and is characterized by leakage of impacted stool. Symptoms are often preceded by social changes, new school, family discord that lead to stool withholding behavior, and in previously toilet trained children, left-sided firmness as seen in this patient, and a palpable fecal mass on abdominal examination further supports the diagnosis. The first step in the management of aneurysm involves treatment of any comorbid conditions. In patients with incorporates laxative therapy, polyethylene glycol often resolves both constipation and aneurysm. Polyethylene glycol. If urinary incontinence persists after successful treatment of bowel dysfunction, other therapies, primary aneurysm, blade wetting, alarm, desmopressin must be considered. Yes. Is it renal vein thrombosis or it is hydronephrosis? Which one? Is it due to like salpingo-frectomy, then the uterus injured, then hydronephrosis? Okay, first look at the renal vein thrombosis. This is very confusing. Renal vein thrombosis does not cause hydronephrosis actually, but it comes with malignancy. Renal vein thrombosis and subsequent unilateral renal infarction can occur in patients in a hypercoagulable state. Malignancy. In acute cases, patients can develop a back pain, costovertebral angle tenderness. However, these patients typically have hematuria. Unilateral ureteral injury is most likely diagnosis in this patient, given her progressively worsening back pain beginning immediately after surgery. So why it is not renal vein thrombosis? Because it comes with hematuria. Yes. Okay. So these patients post-operative unilateral back pain, nausea with vomiting and costovertebral angle tenderness are most likely due to hydronephrosis from ureteral injury, gynecological surgery, particularly hysterectomy. Particularly hysterectomy has the highest risk of iatrogenic ureteral injury due to the proximity of the ureters to the pelvic organ, particularly the uterine artery. The risk of ureteral injury increases in patients with obesity, distorted pelvic architecture from malignancy, as in this patient, mm, or prior pelvic surgery, cesarean delivery. Ureteral injury most commonly occurs due to accidental suturing. Ureteral injury most commonly occurs due to accidental suturing of the ureter during uterine artery ligation or vaginal cuff closure, which can cause partial or complete ureteral obstruction. Patients with ureteral obstruction develop hydronephrosis. However, symptoms can be masked initially by postoperative pain medication. With continued obstruction, patients have non-radiating back pain and postoperative angle tenderness because only one ureter is affected. Patients typically have normal renal function, normal creatinine and urine analysis. However, irreversible renal damage can occur if obstruction is untreated. Diagnosis can be made by renal ultrasound and treatment is surgical. Okay. Okay, this patient who is at 99 percentile for weight, who is at 99 percentile for weight and has a large tongue, asym asymmetric enlargement of right leg, asymmetric enlargement of the right. These findings are concerning for Beckwith-Wiedemann syndrome, an overgrowth disorder with a predisposition to neoplasm. Most patients have sporadic or inherited alteration of the chromosome 11p15, which includes genes that encode insulin-like growth factor 2 at birth. Classic physical findings include macrosomia, macroglossia, hemihyperplasia, hemihyperplasia, overgrowth of one side of the body, and midline abdominal wall defect, umbilical hernia, omphalocele. Some infants also have visceromegaly. Newborns must be monitored closely for hypoglycemia because fetal hyperinsulinemia can result in profoundly low blood glucose at birth. Patients with Beckwith-Wiedemann syndrome. Patients with Beckwith-Wiedemann syndrome significantly increased risk of embryonal tumors such as Wilms tumor and hepatoblastoma during early childhood. Therefore, beginning at diagnosis, serial screening via abdominal ultrasound should be performed to assess the kidneys and liver at age 8. Serial serum alpha fetoprotein level for hepatoblastoma screening should be assessed until age 4. Okay, look at the box. Beckwith-Wiedemann syndrome. Dysregulation of the imprinted gene expression on chromosome 11p15. There may be unregulated growth, fetal macrosomia, rapid growth in children. There may be macroglossia, hemihyperplasia, midline abdominal wall defect, there may be omphalocele, umbilical hernia, embryonal tumor, there may be Wilms tumor, and hepatoblastoma. Abdominal ultrasonography, serum alpha fetoprotein. This patient has large tongue, but that means hemihyperplasia. I'm sorry, macroglossia. And and what are other findings present in the study? Uh, Macroglossia. Yes. Okay, uric acid stone. Uric acid stone, renal colic with no stones identified on abdominal X-ray. Renal colic with no stone identified on abdominal X-ray can be due to the following situation: radiolucent stone, uric acid stone, xanthine stone. Small calcium stone less than 1 to 3 millimeter in diameter, non-stone ureteral obstruction, bad blood clot tumor. Mm, tumor. This patient has uric acid stone which are radiolucent on X-ray but can be seen on CT scan. Uric acid stone account 5 to 10% 5 to 10% on urolithiasis and can be are most commonly seen in patients with persistent low urine pH and hyperuricosuriac gout myeloproliferative disease. Low urine pH is a major risk factor because the solubility of the uric acid significantly declines as urine pH decreases. Conditions that may cause persistently acidic urine include chronic diarrhea due to enteric bicarbonate loss and diabetes mellitus or metabolic syndrome. Anti-metabolic treatment include hydration and alkalization of the urine, low purine diet, hydration, alkalization of the urine, low purine diet, alkalization of the urine uh, uh, to pH 6 to 7, and oral potassium citrate is recommended because increased urine pH increases uric acid solubility and promotes dissolution of the stone. In addition, citrate is a stone inhibitor that reduces crystallization. Allopurinol can be added if symptoms recur despite initial measures, especially if hyperuricosuriac occurs. So, in treatment of the uric acid stone, like alkalization of the urine with potassium citrate and reduction of uric acid production by giving low purine diet and allopurinol. Okay.